Eddie, do you want to have any opening remarks? Do you want to say anything? We are being recorded, just so everyone knows. I think you have to accept that anyway, but do you want
Yeah,
to say anything, Eddie?
just a brief intro and a welcome on behalf of VCSQI. Thanks so much for being here today for our monthly Quality Committee conference call and Zoom meeting. We have a special guest presenter who will share some great perfusion slides in just a few moments. Welcome to Meetali. Thank you for being here. But first, we just have a couple slides from Judy and updates from her perspective. So Judy, feel free
Um,
to jump in.
okay, I hope I have to be sure. I think I'm sharing a screenshot with an adorable puppy dog. This is Blythe's baby, Sadie. Do y'all see that screen, Eddie?
Yes, it's visible. Yes.
Yes.
Thank you. Thank you. So this is little Sadie who's like, I don't think so. This was from the January snow, but that was, I don't know, too cute not to share. Yeah. So I'm sure most of you were on the call for the AQO call on February, I mean, the not AQO, but the STS call on February the 5th. But if you were not, we do have our dates. It's only going to be 2 days this year. It's going to be in San Antonio. They have not published the place yet. They're working intentionally to make it less expensive. There will be a virtual option, just like last time. They are accepting live posters as well as virtual posters. They are going to correct this year to say 2 and 3. What they removed was PD Max and Intermax will both be virtual and like a live virtual and then a virtual sessions. They will not be at San Antonio. They're going to have their own things. So I know that some people have had questions for save the dates and trying to get money. They have not figured out the cost yet, and we don't know the hotel yet, but at least we got dates yet to block on your calendar. So I wanted to share that. We do close on the 20 Friday here. It closes on, I thought it was the 21st.
It is.
Okay, so the harvest is going to close on the 21st and it's going to be at midnight, like the minute before midnight. This was just a typo, but I wanted to say that. And exciting, where Melinda is starting, she has got like a whole new series that kind of was, I think she packed in everything and she's on the call. Sorry about that. Here, let's just go this. She kind of packed in everything into 2 hours and then just realized there's so many changes and so much data. They're going to be like these calls that are going to start. It's going to be on a Tuesday. I believe it's going to be 12 o'clock your time, but we'll get the invites for these. And it kind of just starts there, and everybody's invited because, like, if you've done this a long time, like me, a lot of things have changed, and there are other resources out there, and things are different. So they're going to be a 7 session series. She did say after that she will resume doing the risk model kind of variables again, like just the basic education. But Melinda, do you want to say anything about this as a little blurb? Sorry to put you on the spot, but I know you're good
No,
at being put on the spot.
thanks, Judy. So, I think a lot of this comes from just the mailbox. I get tons of questions about things like this. And so, um, and it's not just from new data managers, it's from data managers that are quite seasoned. So I think with all the changes and the new things that have come out, then it's worth putting a program. I guess we call this a program together like this, so that you have these resources. I won't be doing the entire training. Nancy will be helping, Carol will be helping, and even Paul and Banu are going to especially be doing session 7. That's going to be their session. So it's going to be it's going to replace the new data manager webinar. We won't have those anymore.
Unify Assura and reimplant with the same.
So I think we're going to need everybody to thank you, Eddie.
And it will be updated as needed. Some of this stuff's not going to change. And then when we have new data managers that come on board, I think this will be a great resource to provide to them for training. And this is not how to do a case abstraction. We have talked about that. That hasn't happened yet. there are some other things in the works this year that we didn't know about that are coming up. So hopefully maybe one day we'll have a training session for abstraction. But right now we're going to start with this, and hopefully you guys will find it useful.
Yeah. Thank you so much, Rhonda. And we'll get invites for this, or just will just be on the website. Do we have to sign up for it, or you just can like log on?
Carol said something on the call about there's going to be a link. There'll be a link on the website, and then it's going to ask you to actually put your name in it so we can kind of keep track of who's
Okay.
attended these sessions. So I'm assuming that will
We'll
be
figure it
coming
out.
up shortly, because the first call is February the 25th,
Okay.
and it's at 10 o'clock my time. So that's Pacific time. So it would
So it'll be
be
1 o'clock here.
1 o'clock your time. Yes.
And then I think we have some mountain friends on today too, which will make that noon for them, I guess. I think. This is just, I just stole Nancy's slides here, but what's interesting about this next data submission that goes through the entire year of 2024, it'll be the first time, and this will be a star rating for the multi-procedural surgery category. And it's going to include the multi-valve, and multi-valve plus CABG will kind of be rolled up into that multi-procedural category. And we did get our STS Harvest 1 that goes through September 30th was released yesterday. If you didn't get that email, it is out there for you on Acuvia. I thought this was interesting. Nancy talked about the exceptional risk exclusion. They've had 100 submissions, 36 were declined just out of hand. I think probably some of those were because they weren't, you have to be in a risk model to actually be included in this. And I'm sure some of them just clearly didn't meet. And so far of those, excluding the ones that are under review, 7 have been accepted as exceptional risks. I thought that was interesting, and I wanted to pass that along. And I think, does anyone have any questions on anything we talked about? So with that, I'm going to let Meetali introduce herself. She's a perfusionist, and she's talked multiple times at AQO, but I feel like I personally needed a review on the cannulation sites, because it's always, especially, when you go from, they go circle rest, and that's going to be in like the second phase, which is going to be on March the 11th, which everybody's certainly invited to that too. But Meetali, you go ahead and take it away. I don't want to take any more of your time up.
Okay, I am going to share my screen. So you see the screen? Do you guys see it?
Looks good.
Yes.
I am
Yes,
assuming
we
you just see one screen, right? You don't see the whole thing. Because
We
on
just see
Zoom
one
it's
screen. It's got the heart, and it says Harvard Medical School, and
okay.
it's one screen.
Because I've done it on Zoom, on other platforms. On Zoom, on my end I see multiple, like my notes on the side, so I just wanted to make sure
Yeah.
you don't see that. So yeah, thanks, Judy. My name is Meetali Mahendrakar, and I work as a clinical quality abstractor at Mass General Brigham in Boston. I am a physician back home in India, and I've done my master's in perfusion sciences. So that's my knowledge from perfusion. So today we'll talk about like perfusion. I'm pretty sure a lot of you already have worked in the OR, but there might be some who have no idea like what is perfusion and what's its role in a cardiac OR. What about it is important, and where is it used, or why do we even need it? And then or when is it really applicable? So I'll try to answer all these questions. So this is like a typical cardiac OR, and as you can see, there's so many screens, so many machines, so many people. There'll be like the anesthesia machines, which is like T machines, a lot of pumps, a lot of cardio, like perfusion machines also. And then there's a lot of people there, cardiac surgeon, fellows, residents, then PAs, scrub techs, nurses, depending upon the hospital. And so these are like two different cardiopulmonary bypass machines. The one in the previous picture was a little big. So as you can see, they come in different sizes, and depending upon the OR, depending upon the surgeon, the choices are made. And just a small blurb of history, like the first time the cardiopulmonary bypass machine was used was in 1953. So it's fairly new technology, just 72-year-old technology. Some other things that perfusionists take care of in cardiac ORs is like this is a HipCon machine, which measures your ACT, and it also analyzes blood to give a heparin dose that would be required. At the end of the case, it also calculates protamine dose that is required for heparin reversal. Some ORs also have their own blood gas analyzers. So this is our Brigham OR. So we have a blood gas analyzer, so we don't have to wait for the blood gases to come back from the labs. This machine here is a cell saver. All it does is it collects all the blood that is collected in your mediastinum, and that whatever that oozes, it's collected in this reservoir along with the heparinized solution, and it gets spun, and the end product is just red blood cells suspended in the saline solution. And the reason I thought I'll mention about cell saver is you might see that, a cell saver bag was given, and it shouldn't be confused with your packed red blood cells. This is not counted for STS, but you see this documented in your anesthesia records or perfusion records. Then, as you can see, there's a lot of screens, but all that information that is being displayed on the screens is very important during the case, and there are multiple screens all around in the OR. This small machine is heat exchanger, and we do read in the op notes in the anesthesia records and perfusion records, like the patient was cooled, a patient was rewarmed. Cardioplegia given is cold, ice cold to begin at the beginning, and then the last dose is a warm cardioplegia. So this small heater cooler is the machine that does all that for patient warming, cooling. So we'll just go over a basic anatomy of the chest in general. So heart is like a muscular pump, which is encased in its own pericardial sac, pericardium, and it lies in the mediastinum between the two lungs in the chest wall or in the rib cage. And circulation is important because we see cannulations being done all over the body, or why venous and arterial are separate, and where they are decides from where the blood is coming, whether it is oxygenated, deoxygenated. So a quick review of circulation. So your superior vena cava and inferior vena cava bring the deoxygenated blood into the right atrium. From right atrium, it goes across the tricuspid valve into the right ventricle. From right ventricle, the blood gets pushed through pulmonary valve into pulmonary arteries, from where it goes to lungs. That's where the ventilation happens. And then the oxygenated blood comes back through pulmonary veins into the left atrium. From left atrium, it goes across the mitral valve into the left ventricle. And then finally, the left ventricle pushes the blood, oxygenated blood, across the aortic valve into the aorta, and then the whole body gets the blood supply. A closer look of the heart. You have superior vena cava, inferior vena cava, and the right atrium, the right ventricle, left ventricle. And this is your aorta. So this is where the aorta will get cannulated, and you read in the op notes like it's the ascending aorta or distal ascending aorta. So it's very small area, but the surgeons do document it based upon where they're it seems like it's a big section of aorta, but it's not. It's a very small section. But you do have different ways of talking about it. And especially in aorta cases, when they talk about zones, it gets even more confusing. So as I said, like again, I just love looking at the pictures because they make more sense when we see like, okay, they say they cannulate right atrium, but if you see SVC, IVC, they both end in right atrium. So sometimes instead of cannulating the IVC, the cannula just goes into the right atrium and it is pointed downwards so that the cannula is IVC cannula, especially for bicaval cannulations. Sorry, I'll go back to my previous picture, sir. So I'd like to talk a little bit about coronary circulation also here. So as you can see here, from the root of the aorta, you have your left coronary artery and right coronary artery. And coronary circulation is what supplies your myocardium, your heart. Remember, heart is a muscular organ, so it needs to be supplied well to pump that blood across. Left coronary artery divides into left anterior descending and left circumflex, and then right coronary goes and supplies on the right side. And the coronary arteries supply oxygenated blood, and coronary veins collect that deoxygenated blood, and all of it is drained in right atrium via coronary sinus. So all blood a coronary sinus is like a small pouch behind the heart, and that's what they cannulate for giving retrograde coronary cardioplegia. So you can see that this is like your coronary sinus and it will be opening there. And this is just another schematic picture showing how the coronary arteries originate from cusps of the valves and how coronary sinus drains back into the right atrium. Aorta is your biggest artery in the body, and it starts at the root, and then you have the ascending aorta, the arch, descending thoracic aorta. The diaphragm divides it into thoracic aorta and the abdominal aorta. The arch vessels are important to know: the left subclavian artery, left common carotid, and innominate artery, which divides into right subclavian and right common carotid. Some surgeons do call innominate as brachiocephalic. It's good to know different names that surgeons call. Once you know your surgeons, you will probably figure it out. But axillary artery or subclavian artery, that's another name that you might see that they use synonymously. Now, closer to the root, sinotubular junction is what divides the aortic root and the ascending aorta. Root is made up of sinotubular junction, the coronary ostia are also part of the root, aortic valve, the cusps of the aortic valves, the commissures, and the the aortic ventricular junction or the annulus. This all comprises of the root. So now about bypass. Why do we need a bypass? So if the surgeon really opens the chest and he wants to operate, imagine the heart is beating, the lungs are going up and down. The surgeon can't do anything. So he really needs a very bloodless field, and it should be quiet. So that's where cardiopulmonary bypass comes into the picture. It is also called as extracorporeal circulation because it is a circulation that is happening outside your body. So that's what extracorporeal circulation really means. And cardiopulmonary bypass is you're bypassing heart and you're bypassing the lungs. So the main goals are like diverting the whole blood from the heart and the lungs, oxygenating that blood, making sure that the blood is well oxygenated, and then making sure that it is getting circulated through the body. And of course, we have some other functions like cooling or warming, and also protecting the heart, which is done by the cardioplegia. So we'll see how it is done. So you drain the blood, the deoxygenated blood from the venous side into a reservoir. From the reservoir, the blood gets through the pump, which can be a roller pump or a centrifugal pump, and through an oxygenator filter, and then it is returned back to the aorta. And when you take it out, your heart is going to be empty. In op notes, the surgeons always talk about different types of cannula, they use different terminologies to explain the cannulas. It can be like staged, it can be tipped, it can be curve tipped, it can be right angled, it's a straight tipped cannulas. So I just have some pictures of venous cannulas here, and all a cannula is just a wire reinforced tube, and some of them have these metal tips which are right angled, and those are used for directly cannulating SVC or IVC. The metal tip ones are not used that much because the chances of injury to the vessels are higher, but they still are available. And then what single stage, double stage, triple stage, or even multi-stage means is, if you can see, there are like baskets of holes at the tip here, or like all at the tips. So in single stage, there's only single like basket at the tip. But if you see at the double stage, there's one basket here and then the other one here. Same here. So when there is two, it's called a double stage. And when there's three, like 1, 2, and 3, it's a triple stage. So all these are used for venous cannulation on the SVC and IVC. Femoral venous cannulas are multi-stage cannulas because they have multiple baskets of these holes, because it's a long cannula that is inserted from femoral vein, and it sits in the tip of the cannula sits in your right atrium. So throughout that whole venous vein, you have to have multiple holes so that there is better drainage. So this is how a bicable cannulation would look like, or sometimes they will be like directly cannulating the SVC or IVC. Even though in this picture you can, as you see, that it looks like both the cannulas are inserted in right atrium, or even in your op note, the surgeon might say that the cannulas were inserted through right atrium. But if he's putting two separate cannulas, one is going towards SVC and the other is going towards IVC, it gets coded as a bicable cannulation. The only thing is, in 4.2, we don't have IVC as a separate site to select from. So even if they cannulate IVC directly, it still gets coded as right atrium. And for bicable cannulations, when they go through right atrium or they directly cannulate SVC, IVC, they get coded as right atrium and SVC. And single stage or double stage or triple stage that are cannulated, like when only single cannula is used, even though it is inserted through right atrium, we have the option of right atrium, but they are sitting, the tip of the cannula is sitting in the IVC. The arterial cannulations can be done in two different ways. Either the cannula can be directly inserted into your vessel, or a Dacron graft is sewn to the artery and then the cannula is inserted into the Dacron graft. This technique is used for smaller vessels like axillary artery or femoral artery, because inserting a cannula in this can again cause damage to the vessel. It can cause dissection, it can cause a tear. So as you can see here, this is your direct aortic cannulation where the cannula is directly inserted into the aorta. This is axillary artery. It can be left axillary, right axillary. And this is the femoral cannula. Again, it can be left or right. Some other cannulation sites are femoral artery and femoral vein. I already talked about femoral vein. As you can see, it's a long cannula and it has multiple holes because you don't want to block the whole vessel, and then there will be a lot of blood on the field, and it will damage also organ damage. And then femoral artery cannulas are small. They either are directly cannulated or through a Dacron graft. Jugular vein, sometimes pulmonary veins are most commonly used for pediatric cases and for left heart bypass, but not on routine cases. So now we have the cannulas that are bringing the blood to the pump and supplying the oxygenated blood on the arterial side. But heart is still beating. It's not full, but it's still beating. And there's still some blood going through the lungs. So for that, we need to isolate the coronary circulation. Basically, we have to stop the connection between the heart and the blood going to the aorta. And that is done by aortic cross clamp. And that can be placed externally, which, as you can see, this is externally placed aortic cross clamp, or it can be placed internally, where a catheter with a balloon at the tip is inserted into the aorta, and the balloon is inflated, and that's how it occludes the aorta, and then the circulations are separated. And I just wanted to make clear that aortic cross clamp and a side biting clamp or a partial clamp are completely two different things. They are not identical. So we only code the aortic cross clamp, which isolates the coronary circulation from the systemic circulation. And that is important when we have to give cardioplegia. Side biting clamp is something that is used only to isolate a small section of your vessel so that anastomosis can be done with the Dacron graft, or it is also used in off-pump cases when to do proximal anastomosis of the vein graft to the aorta. And I just have some documentation that you will see for aortic cross clamp and side biting or partial clamp. So when you see that it's documented as a cardioplegic arrest or diastolic arrest, that tells that the heart is stopped. And to stop the heart, they have to put a cross clamp. Or you will see that a cross clamp was applied, very easy, straightforward. They say a single cross clamp technique was used, or aorta was cross clamped. Sometimes they say like heart was arrested and then the aorta was cross clamped. For partial clamp or side biting clamp, they will, as I said, most of the times it's used in off-pump cabbages, and when they are doing proximal anastomosis for the bypass grafts and the chimney graft or the Dacron graft that I showed in aortic cannulation. To sew that Dacron graft to the vessel, they do use the side biting clamp. And the documentation will be something like this, like the proximal anastomosis performed over a partial occluding clamp on the proximal ascending aorta, or vein graft was brought up over to the right atrium and anastomosed to the proximal aorta with the help of side biting clamp. So I hope this helps. Now we have isolated the heart, but we need to stop it. We need to stop it in a relaxed stage. So that is done by cardioplegia. Cardioplegia is the main ingredient of the cardioplegia is potassium, because potassium relaxes your heart or stops your heart in a relaxed state, or like in technical terms, it's diastole. And it also has magnesium, or it can have sodium bicarbonate, it can have lidocaine. Like the solution, there are different solutions, and some surgeons like to use some solutions, or sometimes it's hospital policy. Sometimes they just make their own solutions. In the OR, perfusionist makes their own solutions. But main ingredient is potassium. And secondly, the first cardioplegia dose is always ice cold. So you want to stop the heart in a relaxed stage, and you also want to reduce its metabolic demands. That's why it's ice cold and it's high potassium. After that, once the heart is relaxed, the success, the next few doses are low potassium, not really high dose, just to maintain that state. And the end of the case, before the clamp comes off, they like to flush everything out with just warm cardioplegia, which does not have any potassium or any other components. It's just warm blood. And so I think I covered that. So cardioplegia routes are either antegrade or retrograde. So antegrade is, the way I always think about it, is like it's the normal course or the forward going force. So it going through the aorta or going through the artery towards the capillary beds. That's antegrade. And retrograde is backwards. So here you are giving it in the coronary sinus. So the whole flow is going against the normal flow. So it's going through your coronary sinus, then it's going through your coronary veins, then coronary arteries, and then it will be coming back at the coronary route. Few other ways that antegrade cardioplegia can be given is through directly into the coronary ostia. There are handheld coronary perfusers, and they just hold it, and the antegrade cardioplegia is given directly into the left and right coronary ostias. And then the other one is through saphenous vein grafts. So when the surgeons are doing the CABG, they first connect all the distal anastomosis. The distal is on the heart, and all the proximal ends of the vein grafts are connected to something called as multiperfuser or octopus. And as they are doing proximal anastomosis, the rest get perfused with the cardioplegia solution. So you sometimes will find it in your documentation that antegrade cardioplegia was given through vein grafts and root. So this is what it means. So that also gets coded as antegrade cardioplegia. So this is how in the chest it looks like. This is like, they say the chest spreader was put in, the chest was opened. This is how your aortic cannula looks like. This is how your venous cannula would be. This is your cross clamp that is isolating the heart from the systemic circulation. Your antegrade cardioplegia, and it's a wide cannula that has a Y, so you have the root vent there with it. You have retrograde cardioplegia cannula, and then this is your vent. So there are some other components of the bypass that are being mentioned in your op notes, and these do not get coded, but because you read them, I just thought I should mention them. So as you saw in the previous pictures, there were the root vent, there was the left ventricle vent or a PA vent. There are field suckers, cell saver, hemoconcentration. All these are there documented, but they are not required for us. So it's just don't get confused with them. So now about coding. This is the section for perfusion. And whenever a bypass is used, you will have these three options to answer depending upon what is being done. None is when no bypass machine is used at all. So it's like your off pump cases. So left heart bypass, we'll talk about it later. Full bypass is what we just talked about, where the whole blood is drained and it goes through the machine and it is returned back, and the heart is arrested with cardioplegia. That's your full cardiopulmonary bypass. And combination can be planned, can be unplanned. An example of combination would be like they start as an off pump case, and then for some reason they have to go change the plan to full. That's a combination which is unplanned. If it is, if it happens because of exposure or something starts bleeding or something gets nicked and they have to crash on pump. Or sometimes another combination that can happen is with aortic cases, they do a full bypass, they do a circ arrest, but because they have to do a bigger section of repair, sometimes they can change a full bypass to a left heart bypass, or it can be vice versa. So that's when combination happens. I have very rarely coded combination. Again, different centers are different, but that's what combination for how I understand a combination. And then arterial cannulation, majority of cardiac surgery cases are going to be aortic. Axillary is for aorta, and sometimes reops. Femoral, again, reops, or the minimally invasive surgeries. They tend to do more femoral cannulations. Innominate, we have never seen it on our end. We most of the time see axillary only, but sometimes they can do innominate also. I'll talk about other in next section when we talk next month. So femoral cannulation, again, as we all know, most of our cases are single cannulas, right atrium. When they are opening the heart for cases like mitral valves, tricuspid valves, or MACE, or pulmonary embolectomies, or heart transplants, or the septal myectomies, those are the cases where they have to cannulate both SVC and IVC because they need to isolate them, like they need to snare it so that they can open and there's no blood coming in. And femoral is for reops, for emergencies, like for dissections. You want to quickly go on pump. They start with femoral and then they can add more cannulas for venous side. Pulmonary vein, jugular vein are more commonly used for pediatric cases or congenital surgeries. But then left atrial, right atrial are used for left heart bypass. They are very case specific, but not something that is done routinely. Then the occlusion, I showed you the proper externally placed aortic cross clamp, balloon occlusion, and then there is none, which will be either your heart will be beating normally, of course, like not in a sinus rhythm, it might be a slower rhythm, but that's your beating heart, and then fibrillating, like it will be documented, the heart is fibrillating, and then they do their surgery. So you'll have to look through your anesthesia record and perfusion record to see if the heart is beating or if it's fibrillating. So I already talked in depth about cannulation. Just remember that it's select all that apply. It's not just one cannula. Code the vessel that gets cannulated. And what that means is even though they are putting the cannula in a Dacron graft, what you should code is the vessel that the Dacron graft is connected to. And then another terminology that is there in the training manual, and it is important when it comes to coding the left heart bypass, is venous cannula is the cannula that is taking the blood out from the patient to the pump. So it's the outflow cannula. And the arterial cannula is the cannula that is bringing the blood from the pump into the patient. So that's why it's an inflow cannula. And about the cardioplegia, again, antegrade is the cannula, the cardioplegia that is given into the root. It is also can be given directly into the coronary ostia, either left or right. So it will be documented in your records as LCO or RCO, sometimes from the proximal ends of the saphenous vein grafts. Retrograde is through coronary sinus. There's no other way to give retrograde cardioplegia. And both would be coded when both antegrade and retrograde are given. And the types are crystalloid, blood, and both. So crystalloid is when only crystalloid solution is given as a cardioplegia. There's no blood at all. And when we say blood cardioplegia, it's some component of your cardioplegia that is being delivered to the heart has blood. It can be one part of crystalloid and 8 parts of blood, or it can be 1 to 16 or 1 to 32. Or another way of giving blood is microplegia, which in those cases, the potassium and magnesium is directly added. There's an algorithm and it's all set systems where just blood is given, but it has some potassium and magnesium only in that. So that's microplegia, but that is still blood. And both is something that I have not seen, but what it means is you are giving some doses of cardioplegia are just crystalloid, and then some are mixed with blood. So I like to have humor, so because it is important. It keeps me happy and it lightens my burden and helps me to focus. So I like to enjoy whatever misprints happen. So I thought I'll share some of my collection with you guys. I hope you also enjoy that. And I think I will stop here until next time. So thank you for your attention. And I hope I have made things clear, not difficult.
Meetali, that was fabulous. We do the same thing. We love this. Is definitely must be a data manager thing. We've got some great ones.
Yeah.
I think, yeah, I'll tell you our favorite one. There are a couple of I don't know if you can read. I had a question. I still don't understand. I know you said that you've got to, so for like septal myectomies, mitral valve, tricuspid valves, they put in that superior vena cava drain also. I still don't understand, like, why don't the rest of the surgeries need a completely bloodless feel? Is because they need completely bloodless feel?
No, the thing is, okay, so I'll try to. So when you are doing anything outside, like you're not really opening up the heart, you have a big, most of the times they put either double stage or triple stage cannula that goes through your right atrium, and it's draining what is coming from SVC and IVC. And you're not opening the heart. So even if there is some blood that kind of seeps in, you have a vent that will take it out. But when you want to open it for, let me see what picture would be better. Just trying to.
Mitral valve is what I always see.
I know. So for mitrals and tricuspids, that's what I didn't plan it for explaining with respect to images.
Sorry.
So here, in this image, if for tricuspid is here, your mitral is here, you are going to open the heart completely. So if you have just this cannula, single stage cannula, once you open it, you are kind of opening that completely open to the air also, and some blood does seep in. So when they have bicaval cannulation, this is what they do. They snare it. So if you can understand what snaring does is the tip is closed. So once you open the heart, whatever is coming from up here is going to go directly into the cannula. Whatever is coming from here is going to go directly into the cannula. Nothing is going to come out. And they open the heart for either mitral or tricuspid or your septal myectomies, even like pulmonary embolectomies or heart transplants. When they snare it, there's no blood coming in and it's quick. So they don't snare it throughout the case. They only snare it when they're opening the heart. And once the heart is closed, they take the snares off. Does it make sense?
Oh my gosh. Yeah. Because I was always with the aorta, because I'm like, well, they don't do it for the aortic valve, but that's
No.
because they cut your aorta.
Yes,
They're
because
not cutting
aorta,
your
your
heart wide
aorta is
open.
here. Yes, for aorta, they're
Right.
going to open it from here, so they can just fix it there. Nothing, it really doesn't matter what is in there, or even if some blood is collecting, they have the root vents and they have the left vent.
Okay, so if you could see me, you would see a light bulb over my head. Does this also impact like de-airing the heart? So basically you cut the heart open, you've got air in it. Do you need those snares back down when you de-air?
De-airing is a completely different technique that they do.
Okay, all right.
When they open the heart, they have a CO2
Okay.
line in there, so they are constantly flooding the field with CO2 because CO2 kind of pushes air out. So there's a lot of other things that are
Okay.
happening, but that will create
We don't have to go there.
Yeah.
And then my other question was, how do they decide if they need a single or double stage?
Single stage would not drain that much. Single stage would be the cannulas that they normally would use for direct cannulations
Okay.
of SVC and IVC. Nowadays, most of the surgeons use double stage or triple stage for majority of their cases. Like when they have just right atrial cannula, that's what they use.
Gotcha. All right, so Erica has a very good question. Erica, I don't know if you want to come off mute and ask this or.
Yeah, so we have a site that does most of their cases off pump for bypass for cabbages. So if you crash onto bypass, usually like you said, they're crashing on using their FEMs and then they're centrally cannulating. So when we abstract, would we then capture the femoral vein, the femoral artery, the aortic, and the right atrium? Would we capture all four things that got cannulated?
It depends. Your surgeons will document if they cannulated all of them. I don't think they would cannulate everything because so there are few things that are documented in any kind of case, especially the off pumps or redo sternotomies and aorta. Before even they start the surgery, they always have the FEM lines. And what that means is they just have a wire going in, they have everything ready to put a cannula in. Having a FEM line ready doesn't mean you have a cannula in there. So
right, I'm talking for our ones that do get crashed on though. We have a good handful of them every year that get crashed on.
Yeah.
So then they would be using those FEMs?
You have to read through the op note. From in my experience, yes, whenever they have to crash on, I don't think they'll put both FEM. They will go on FEM and have a central cannulation also. If they have a good drainage with FEM cannulation, they don't really need to have central cannulation. It depends. If they are not able to have enough drain, like venous drainage, then they might think of adding cannula. So it's all depends upon case. Like I need to read the op note to tell you what to code when.
Right, but if they do clearly, I guess my question is if they clearly state that, you know, we crashed on using our FEMs, then we transitioned to central.
Then you will have
because
to
that's what
code
ours
both.
usually say. We
Yeah,
code
so-
both. Okay.
Yes,
Okay.
then you will have to code both. Because
Okay,
it is, as
thanks.
I said, it's select all that was used.
Okay, thank you.
No problem.
Jennifer has a great question. Can you clarify the types of cardioplegia again? Crystalloid is the most common. We use blood exclusively over here. This isn't documented well at my site. So
yeah.
I think how do you sort out? I mean, other than just writing your perfusionist, how do you sort that out?
Perfusionist is the one who can really tell you if they use blood or crystalloid. Again, for centers that I have worked so far, we have always have that documentation of the percentage or if we are using the microplegia. That's how it's documented in our perfusion records.
Meetali, can I say something?
Yeah, sure.
So just crystalloid's pretty an old practice. I mean,
Yeah.
I can't imagine you're using just crystalloid.
Mm-hmm.
Unless your surgeon's really, really old, then maybe you are. But that's something that was used a long time ago, not used very often. So I would, Jennifer, look at that a little closer because
Yeah.
I suspect you've got some blood mixed in there.
Yeah.
Even something like Del Nido that's like 2 or 3 liters. So you think, oh my gosh, it's got to be, but Del Nido counts as blood,
Right.
cardioplegia.
Yeah,
We use
anytime you've
mostly.
got blood mixed in, 4-to-1,
Mhm.
Del Nino, anything like that, that's blood cardioplegia. So it's pretty rare when they're just using crystalloid.
I think as the industry has kind of moved toward not giving as much blood and really being sensitive to, how you give 2 or 3 liters of crystalloid, you're going to drop your hemoglobin and your hematocrit, and it might push you to blood. So I'm to give blood to patients. So I think that's
And I
probably an
think
older
it's
practice.
different for pediatrics than for adults. And as Melinda said, like crystalloid was very old thing, and now they're all moving towards adding some portion of blood. And microplegia is like the best, where it's all just blood with just potassium in there. But I think the perfusionist would be the best person to ask if they have any blood in that. Like, I think that's what her question was, like, how do we figure it out? You will have to ask your perfusionist, right, Melinda?
Correct. Yeah, you should clarify that because that seems strange. It was just
Yeah.
crystalloid.
Tim has a great question that I think is really good to clarify. So if the op node says dual stage cannulation, is it coded the same as bicable cannulation?
No, dual stage that's exactly like this. What I showed in my slide was the single stage, double stage. Double stage is also called dual stage cannula. So bicable would be documented as bicavally cannulated, or 2 cannulas were used. Dual stage is another synonym that is used for double stage, as far as I know. Unless you're seeing that there are 2 separate cannulas documented, like the surgeon is saying that he put 1 cannula in right atrium for IVC and the other one in SVC.
Yeah, I think the difference here is 2 cannulas. So
Yeah.
bicaval, you have 2 cannulas.
Mm-hmm.
A dual stage or a double stage cannula is 1 cannula with 2 holes in it. That's the difference.
Yeah.
But it would be possible to have bicable cannulation with 2 double staged cannula. It's the number of cannula you put in.
Yes, it's the number of cannulas and where they are draining from, like what vessel they are directed to.
So Kim, you just come off mute if you have questions about that, because it was a great question. Deb's asking, where does the additional catheter or the LV vent come in?
They are sitting in, that's why I like pictures. So LV vent, it goes through your pulmonary artery and it sits in your left ventricle. So as I said, it's LV vent. It sits in the left ventricle, but you don't need to code it. And same with aortic root vent. It is in your root, but you don't need to code it. The vents, the suckers, hemoconcentration, cell savers. I know there's so many wordings in the op notes, and we want to be accurate with what we are coding, but we don't need to code them.
But tell us why we have them.
I was going to say what I was going to say. Meetali, explain what the vents do.
Okay. So I'll start with the aortic root vent. So you're giving cardioplegia. This is closed. So systemic circulation, it cannot go in the aorta, and it will go back in your right atrium through the coronary sinus, and it will be drained in your venous cannula. But not all the blood really goes through. Like there will be some sitting in the root, and you don't want it to be like a balloon filled with blood. And it's coronary circulation. Eventually, some will be coming out. And again, heart is as I said, there's a lot of other vessels that are draining into your heart. So even though we are draining all the systemic circulatory blood, but whatever blood is still in the myocardium is going to collect somewhere, either in your left ventricle, right ventricle, and the cardioplegia that we are giving, some of that will be staying in the root. So you don't want it there, and that will cause damage to the vessel, to the wall and the vessel. So you want to drain it back. So that gets collected, and that's what the root vent or the left ventricular vent does. So whatever blood gets collected or seeps in there, that gets pulled back. The vent, both the vents are connected to the pump, and it's slowly sucking it in. So that's what they do. They, whatever little bit blood gets collected, they suck it out. Make sense? Did it make sense?
It makes sense to me. I just want to be sure. Jennifer just come up. Yeah, Deb says yeah.
Can I say something to Deb?
Yep.
It's
Yeah.
off the subject, but Deb, I keep trying to send you an answer to your FAQ, but it keeps getting sent back to me. So if you could just type your email to me in this chat box, I'd appreciate it. Thank you.
Well, Meetali, we cannot thank you enough. If there are any other questions for her, we've got another minute or two, but this was amazing and so helpful. Really appreciate it.
Thank you.
All right, and Deb, be sure you get your, yeah, there you go, Deborah.Schill@froedtert.com. Did you get that, Melinda?
I got it. And I think that's the one I've been sending it to, which means that you probably have me blocked. Oh, yeah, because that's the one I've been sending it to. So I think maybe not. Let me try. I'm going to do this. Looks maybe there might be a slight difference there.
All right.
Hopefully
Well,
you'll
thank
get
you,
this one.
everyone, and thanks our friends from across the country who've joined us today. Super appreciate you joining, and definitely so happy to have you here today.
Thank you.
Thank you.
Thanks so much, everyone. Thanks, Meetali.
Thank you.